My name's Louis Brown, and I'm with the Christ Medicus Foundation. I'm the director of the Christ Medicus Foundation's CURO Catholic Healthcare Ministry. It provides a national Catholic healthcare option for individuals and families across the country. We have members in 47 states. We work together with Samaritan Ministries International. They have 60,000 households across the country, over 150,000 people. And the mission of the Christ Medicus Foundation truly is to advance the culture of life within healthcare at the legislative level, working with Catholic primary care centers and Catholic medical professionals, but also providing the Catholic healthcare option that we do, and just truly building a culture of life, working to transform healthcare in general. We really appreciate the Catholic Information Center, Father Arnie Panula, Mitch Boersma for providing us this opportunity to use this space. Also, thank you to John Coe and Rosemary Holt. The events called the changing face of healthcare in the 2016 election. Open enrollment began nationwide yesterday, and millions of Americans are making healthcare decisions for themselves, for their families, for their employees across the country. That's happening right now. On the state and federal exchanges and the private individual market, costs are increasing at levels that were unexpected, and it's pretty clear that there's bipartisan agreement that the system's broken, that it's not working as it should. We also have a federal election that's just days away. Our new president and Congress will potentially have an enormous impact on healthcare generally. There's a lot of decisions that they're going to have to make, and they're certainly going to have an impact on the unresolved issues surrounding religious freedom in healthcare, not to mention they will potentially advise and consent on new U.S. Supreme Court justices, at least 3, perhaps as many as 4. In the midst of all this, we are here today, the Catholic Medical Association, represented by the president of the Catholic Medical Association, Dr. Lester Ruppersberger, Dr. Duane, Matt Bowman. We're here today to provide a couple of different messages. The first is to urge Catholics, Christians, and all Americans across the country, people of goodwill, to make healthcare choices that support human dignity, the right to life, and religious freedom during this open enrollment period. That has an enormous impact on the level of the dignity that we have as a country, on the level of civility that we have as a country, on the level to which we value human life in the United States of America. The second message we have is to discuss the challenges in the healthcare environment today across the board for American consumers who are patients and also for medical providers. We also want to highlight new trends in healthcare that we think are really exciting. That includes health sharing, it includes direct primary care, but what it's doing is at a lower cost, providing a more affordable way of providing for people's healthcare needs in a way that goes to the person, in a way that goes directly to the patient, and goes back to what healthcare was always supposed to be about, which is a relationship between a patient and his doctor, a relationship between the individual and his family, the relationship between the family and the community. We also want to talk about the ongoing religious freedom issues in healthcare. A lot of folks think that the Hobby Lobby decision occurred, the Zubik v. Burwell decision occurred, and those issues are resolved. They're not resolved. We're going to see over the next months and years the U.S. Court of Appeals really play out exactly what they believe the U.S. Supreme Court decided in the Zubik v. Burwell case. We're also going to see variations, most likely, of what the court decided in the Hobby Lobby decision, and that's going to play out in the courts across the country and perhaps again at the U.S. Supreme Court. So we want to talk about this today, but the overarching message is we want Americans across the country, Christian, non-Christian, Catholic, non-Catholic, to make healthcare decisions consistent with the culture of life, consistent with human dignity, and we're just so happy to have you all here today with us. With that, I'm going to introduce our moderator today, our extraordinarily distinguished moderator who seems to be everywhere, around the universe except for perhaps Mars, and she's just an amazing person. She's the former editor and current editor at large of the National Review Online. She's written and edited for more than a decade, and she's a senior fellow at the National Review Institute. Kathryn Lopez is just such a dynamic voice across the country on so many different issues. You can't really peg her into one universe or one community of thought. She truly is a thought leader and looked to across the country and internationally to provide leadership in where we're going as a country, and also is just an outstanding journalist. And so with that, I introduce to you Kathryn Lopez. Thank you so much.
I feel like I need to go to Mars now. That's a solution to not having to pay attention to the election anymore. I'm really grateful to be here because part of the reason we have this car crash of an election is because people are fed up with Washington, D.C., not dealing with serious issues that affect their lives. And because of the utter confusion, there are so many layers of confusion, people don't even know where to start. And I remember, as Lewis was talking, it was 4 years ago, and we had two Catholic vice presidential candidates. I remember at the debate who were talking about completely different realities when it came to religious freedom and healthcare. And herein lies the problem. I'm really grateful always to be at the Catholic Information Center because here we are in Washington trying to think through what it means to be a Catholic in the public square and in public policy, in all roles. And I'm really grateful to CMF CURO because one of the blessings of the in a weird way of the Obama administration's Department of Health and Human Services mandate that has put the Little Sisters of the Poor and everybody else in court is it's forced us to deal with these issues of, okay, what does Catholic healthcare look like now? In the last century, it was beautiful women religious running hospitals, and a lot of those hospitals aren't Catholic anymore. And there's so many layers of questions and problems. And so thank you for coming here and spending a little time thinking about real issues that affect people's lives, a sort of a slow, sober return to reality that we'll have to deal with the morning after the election a week from now. I'd like to begin by introducing, we've already got a little intro to Dr. Lester Ruppersberger, who is the president of the Catholic Medical Association, and he's going to talk to you for a few moments about his outlook on what's going on today and some of our challenges. And here you go. And it's up to you if you want to stand at the podium or whatever you're more comfortable.
A little bit easier, I think. As unaccustomed as I am to using microphones and being on the stage. Hi, good morning, everyone. I'm Dr. Lester Ruppersberger. I came down from Philadelphia this morning. So thanks be to God for all of you giving your time and attention to join us at this forum to discuss a topic of great import and impact both to ourselves, our church, and the people of this nation. The Catholic Medical Association recognizes the importance of the need to reform the healthcare delivery system in the United States. In 2004, the CMA published a document addressing this vital issue entitled Healthcare in America, a Catholic Proposal for Renewal, with specific policy proposals based upon the moral and social teaching of the Catholic Church. Now, a decade later, very little of the massive federal healthcare reform legislation enacted is in conformity with that Catholic tradition. In that white paper, the CMA task force outlined the crisis in American healthcare. This crisis transcends and indeed explains the crisis of coverage. The number of uninsured in the United States currently stands at approximately 28.5 million, with a decrease of 13 million since 2013, as per the Kaiser Foundation. But even with the Affordable Care Act, 46% of uninsured adults said that they tried to get coverage but could not afford it. In addition, we have a number of Americans who are misinsured, who work but cannot obtain coverage, who could not obtain coverage that matches the varying needs of their life cycles, or most importantly, could not obtain coverage that accords with their fundamental moral beliefs. Indeed, it can be said that the misinsurance of America, defined as the systematic, inequitable, and unjust allocation of public and private resources for health purposes, is a near universal phenomenon. Just as cogently, the crisis in American healthcare is more than a crisis of the insured and the uninsured. It's a crisis afflicting the patient-physician relationship, which has been eroded by factors that include financing healthcare, but that are more properly understood as having their roots in the loss of the common understanding, both within and without the medical profession, of the sanctity and inviolability of each human life and the dignity of the person. We believe that the Catholic Church has the opportunity to provide the guidance necessary to enact meaningful healthcare policies that could uphold the sanctity of life from conception to natural death, as well as the common good, and to do it in a financially sustainable fashion. This meeting of invested in caring individuals are called to reflect upon the opportunity and the responsibility that we have to bring the message of healing and mercy given to us by our Lord and Savior Jesus Christ to the public square and to build a culture of life in healthcare. The number of Catholic-owned or affiliated hospitals in the United States has grown by 22% since 2001, and now 1 in 6 acute care beds is in a hospital connected to the Catholic Church. In 2014, the Church had 38,275 diocesan and religious order priests, over 30,000 lay ministers, 17,500 men who are ordained as permanent deacons in the United States, 49,883 sisters, and 4,318 brothers, 16 United States cardinals, 424 active and retired U.S. bishops, and 3,631 seminarians enrolled in the United States. It employs more than 1 million employees with an operating budget of nearly $100 billion to run parishes and high schools, secondary schools, nursing homes, retreat centers, diocesan hospitals, and other charitable institutions. Catholic schools educate 2.7 million students in the United States, employing 150,000 teachers. In 2002, Catholic healthcare systems overseeing 625 hospitals with a combined revenue of $38 billion comprised the nation's largest group of nonprofit systems. In 2008, the cost of running these hospitals had risen to $84.6 billion, including the $5.7 billion they donate. According to the Catholic Health Association in the United States, 60 healthcare systems on average admit 1 in 6 patients each year in the United States. Due to mergers and acquisitions over the last 15 years, 14.5% of all acute care hospitals in the nation are now owned or affiliated with the Catholic Church. In 10 of the U.S. states, the number of Catholic hospitals is more than 30%. There are over 625 Catholic hospitals, as mentioned, with hundreds of Catholic medical clinics and shelters and 5 Catholic-affiliated medical schools. On a larger scale, the Roman Catholic Church is the largest non-government provider of healthcare services in the world. It has about 18,000 clinics, 16,000 homes for the elderly and those with special needs, over 5,500 hospitals, with 65% of them located in developing countries. Pontifical Council for the Pastoral Care of Health Workers has stated that the Church manages 26% of the world's healthcare facilities. The ethical and economic challenges in healthcare are overwhelming, but with the grace of God and the sure hope of His will, we must work to continue the Church's ministry to the sick begun by Christ Himself. The 2004 CMA document mentioned previously on healthcare proposals is in need of updating in light of the many changes that have been made in the healthcare sector since then. And in November of 2016, our publication, the Lineker Quarterly, will be dedicated to health reform, a Catholic perspective, and will bring together many voices and many different perspectives from different areas of expertise to address the important topics regarding authentic reform of healthcare delivery in conformity with Catholic and moral and social doctrine. The challenge is to create new incentives that drive the power and the responsibility of purchasing health insurance away from specific employers and government bureaucracies and toward the individual worker and family. Changes in public policy are needed to foster a renewed climate in which individuals and families are free to make decisions about their health care and its source based upon their conscience. This will serve the principle of subsidiarity, confirming the right and the ability of the worker to dispose of his or her wages to serve his or her own basic needs and that of their families, while mitigating barriers that interfere with the physician-patient relationship. The Affordable Care Act contains a mandate that coverage of preventive services that established a process for determining which health care services must be provided in all United States health plans on a preferred basis. That is, without coinsurance, without copays, the application of deductibles, or any other costs to the consumers. For example, contraceptives that have abortifacient properties. However, someone must pay for this service, which is why premiums are expected to increase in some states like Pennsylvania, where I live, over 50% in 2017, with an average of 23% increase for all affordable care plans in the next year. And many private insurers are withdrawing from the marketplace, such as Aetna and United Healthcare. In fact, many predict that the ACA has been an abysmal failure and will fail under the weight of its own financial excesses. The intrusions of third parties between the physician-patient relationship has been an ongoing problem that can be resolved by direct care models and restoration of that relationship, both from a medical as well as a fiduciary perspective. There are 6 primary tenets that the Catholic Medical Association would recommend that be incorporated into any healthcare policy changes. The first is individual ownership of health insurance. Every American should be able to obtain needed medical care, and reforming the tax treatment of health insurance costs is indispensable to achieving that goal. The second is freedom from health insurance mandates. Individuals and families need more than equal tax treatments in order to purchase a health plan of their choice. They must be able to purchase insurance that is free of restrictions and bureaucratic dictates, especially state and federal insurance mandates. The third is a choice of private health policies. A wide choice of affordable health care policies exists for government employees and a few others. Catholic social policy has endorsed and supported the formation of various kinds of worker and family organizations, from labor unions to fraternal benefit societies to healthcare sharing ministries, for decades. The fourth is health savings accounts. The interests of families are also served by public policy that allows them to finance and control more of their own discretionary and routine health spending through tax-preferred health savings accounts. Families who open an HSA must also purchase a high-deductible health insurance policy that functions as real insurance, protecting the family against the risk of any major medical expenses. The fifth is comprehensive protection of conscience. No reform in the American healthcare system will restore the physician-patient relationship if healthcare workers are not afforded comprehensive protection of conscience. The current patchwork of laws and private sector policies that has woven a fabric of doubt among healthcare professionals. Currently, the governmental attacks on individual conscience rights, accompanied by mandates that, quite frankly, are violations of the Hippocratic Oath, along with insurance mandates, have fractured the trust in healthcare professionals who are avowed to do no harm and respect the dignity of the person. And finally, experiments in diocesan self-insurance and possibly even a national Catholic health plan will offer to the faithful an opportunity to act in full service to life. The CMA embraces the need for ever more insightful and comprehensive study of models of authentically life-promoting and respectful health care, and we support significant new investments in scholarship and public policy research to stimulate and advance the dialogue. This forum is meant to be begin the meeting the need of this reform, and will be the first steps requiring an ongoing cooperative process within the church and related organizations to develop and then promote implementation of specific recommendations in reforming the healthcare sector and the delivery of healthcare. Thank you very much, and have a good day.
Next, I'd like to invite up, or feel free to stay sitting, Dr. Marguerite Duane, who is a family physician and adjunct associate professor at Georgetown University. She's co-founder and executive team leader of FACTS, the Fertility Appreciation Collaborative to Teach the Science, and she formerly was the medical director of the Spanish Catholic Center of Catholic Charities here in Washington, D.C., in the Archdiocese of D.C. Thank you, Doctor.
Thank you. I'm delighted to be here, especially today. Today is a very, very special day for me. Today marks the 37th anniversary of the day that I decided I was going to be a doctor. Now, you may wonder how I can know exactly that to that day, and you may wonder how old was I possibly when I made that decision to be a doctor, and I'll tell you, I was 8 years old. And on this day, 37 years ago, I sat at my mother's feet and watched my baby sister be born into this world. I watched my mother suffer through the pain of labor, but I watched her surrounded by a community of friends and family and support her as she brought a new life into this world. It was at that moment that I truly appreciated the miracle of life, that I was in awe of the doctor that stood at my mother's side, an OB, in fact, who did a home birth in New York, of all places, if you could imagine, as I watched my baby sister come into this world. And I knew then that I wanted to be a doctor. I knew then that I wanted the privilege to be a part of such a sacred relationship between two human beings. I've always believed as a physician that we are blessed to be able to form these relationships with our patients, a relationship that can only be matched by the relationship between a pastor and his parishioners. As physicians, our patients trust us with the intimate details of their lives. They look to us for guidance and for advice, and to help support them and respect them. As a physician, I decided shortly thereafter that I wanted to be a family physician. And why was that? I think it's because of the model that my family showed me. You know, the model that my mother showed me as a nurse, caring for people regardless of their walk in life. She worked in prison, she worked on drug and alcohol units. She cared for people that many of us would reject as not being worthy. But what my mother showed me, and what I've strived to follow throughout my career as a physician, that every single one of us is worthy. We are each made in the image of Christ, and we each have human dignity, regardless of what we're able to do, regardless of how many days we may have left on this earth, regardless of how many days we may have been growing in our mother's womb. Each one of us is a human being and deserving of respect and care and protection. I have to say today is also a very sad day because just one day ago, the DC Council passed the assisted suicide legislation, calling on my colleagues to help us kill our patients. More than 2,000 years ago, on the island of Kos, in the country of Greece, at the temple of Asclepius, Hippocrates developed an oath that physicians were to take, an oath that would say, do no harm. Do not give to a woman a pessary to cause an abortion. Do not give a medication that would hasten death. In 2002, on this very day, 14 years ago, I stood at the temple of Asclepius and I took that Hippocratic oath. And I carry that through with me every single day when I care for my patients, whether it was in my residency program in Lancaster General Hospital, to my role at Georgetown when I'm teaching medical students, to when I served as medical director of Catholic Charities. At Catholic Charities at the Spanish Catholic Center, we care for patients who are uninsured, many of whom are undocumented, many of whom have very limited resources. I started there in 2008, and during my tenure there, the Affordable Care Act was passed, and many people said to me, you must be so excited. Now all of your patients are going to have insurance. And I thought and often would respond to, well, no, actually, I'm not. Because one, and many of our patients at the Spanish Catholic Center would still not have been covered. And regardless of if they were, what I would tell people, health insurance does not equal health care. I'm sure many of you know people that walk around with a health insurance card that can't get access to care. In fact, at the Spanish Catholic Center, where we only cared for the uninsured, I would have patients call me frequently saying, I've got Blue Cross, I've got Medicaid, I've got Medicare. Can you see me? Because I can't find a doctor that will take my health insurance. I had one woman call, say, I've had back pain for 2 weeks. I can get in to see an orthopedist next week, but I can't find a family physician that can see me for 6 to 8 weeks. So health insurance does not equal health care. The other thing that I learned at Spanish Catholic Center, where again, our patients were poor and uninsured, we did not require them to pay for services. We merely asked them for a contribution for their care. And what we requested at that time was $40 for a visit. Can I tell you, for my patients, $40 might have meant a week's worth of groceries. $40 would have paid their electric bill for the month. On average, our patients contributed $32 to the cost of their care. Part of it is that, again, that dignity, that self-worth. As patients, they valued what we could provide them. And what we provided them was time, caring, understanding, guidance. We provided health care that was in accordance with their goals, that respected their conscience, that did not discourage them from using a natural method of family planning when they were told, well, they must get an IUD because they've had 3 kids and they've clearly met their quota. So we cared for people regardless. And what I discovered is healthcare doesn't actually cost a lot. At the Spanish Catholic Center, our patients would have to pay for their labs out of pocket. Now, I'm sure that would make some of you shudder. If you've ever seen a laboratory bill, maybe you've had to have a cholesterol check, maybe your thyroid was checked, and you might think, oh my goodness, a cholesterol panel. What does that cost you? If you've ever looked at an insurance bill, $150, $200. Do you know what my patients paid for that? $5. Because that's all it really costs. Much of our healthcare cost does not actually pay for health care. It covers the administration and the bureaucracy that we continue to build and expand, and has only hastened and worsened with the Affordable Care Act. All of this money that we are putting into this healthcare system is not helping people get healthier. It's helping government grow bigger. It's helping government to have a greater control in our lives and a say over what we do. But it's not actually helping patients get healthier. Tell me, how does an assisted suicide legislation help a patient who's suffering in their final days with cancer? How does that help them in their quality of life? As I listened to Les and he talked about the role of Catholic hospitals, I thought to myself, I've been very proud to be affiliated with Providence Hospital here in Washington, D.C. But I've also seen that they are struggling as part of this bigger system. Again, at Spanish Catholic Center, our patients had no insurance, and so they paid everything out of pocket. And I had one patient who came to me very sick with a fever and back pain, chills. She'd been trying to get better at home, drinking lots of fluids. She knew it might have been a urine infection because she'd had them before. When she'd come to see me at the clinic, I knew it had progressed and it had now infected her kidneys. We did everything we could for her at the clinic. We gave her IV fluids. We started her on antibiotics, but she clearly couldn't tolerate anything by mouth, so I knew we needed to admit her to the hospital. And so I had privileges at Providence, and I wrote her admitting orders, and we had done her labs there in the clinic, and I sent her over strictly with orders for fluids and IV antibiotics. She went over with a family member, and I said to her, I would stop by in a few hours on my way home from the clinic on my way to my home. And when I did, I stopped and I checked in. She'd fortunately bypassed the ER, which would have, charged her $2,000 or $3,000 to step foot in the ER. We were able to direct admit her. I found her in her room, and next to her were 4 vials of blood sitting there. And I looked at them and I thought to myself, I didn't order any lab work. And I asked the nurse, I said, what's all this blood here for? She's like, well, it's for labs. I assume you're going to order admitting lab work, right? And I said, no, I sent over my admitting orders. The only thing I ordered was IV fluids because I've already done her labs today. And again, doing them through my clinic, I knew it would cost her about $30 instead of $300 or $400. But she said, but every patient gets admitting labs. And see, that's the way our healthcare system sees patients. They're a number. Every person that walks through this door must need labs. Well, I will tell you, I don't see patients as numbers. I see them as individuals. And many of my colleagues want to see their patients as individuals. But they are stuck on this treadmill of having to see 20, 30 patients a day. And it's hard for them to see them as individuals. My experience at Spanish Catholic Center, which was preceded by my experience at a federally qualified community health center, where I did full spectrum family medicine, including prenatal care, including well child care, but in a setting where I had to see 20 patients a day, many of whom didn't speak English, many of whom had many other issues. My experience at Spanish Catholic Center showed me when you have time with patients and when you get the administrative aspect of insurance out of the exam room, you can have more time with patients. And so it led me to form a direct primary care practice called Modern Mobile Medicine with another family medicine colleague of mine, Dr. Matthew Hayden. Together, Dr. Hayden and I desired to bring healthcare to people in their homes. So I see patients in their home, at their job, sometimes outside of Starbucks. I even talked to one mom at the pool while our kids were having swimming lessons together. As physicians, as a physician, as a family physician, I want to be able to meet people where they're at. And people often say, well, you know, direct primary care, that's concierge medicine. That's all well and good for the wealthy, but that doesn't work for the poor. I will tell you, for our practice, it's $79 for a monthly membership fee. Many people pay more than that for their cell phone bills. For a family, it's $200. Whether there's 3 of you or 13 of you, doesn't matter to me. And so direct primary care can be affordable. And it gets back to insurance. What is the purpose of insurance? Why do you have car insurance if you drive and you own a car? Do you have it to cover the oil change that you need to get every 3,000 miles or 3 months? Is it for the flat tire that you might get every few years? Maybe it's to cover the fender bender when you're parked in DC and, you know, that happens to every single one of us. We get those little dents and dings. No, that's not what your car insurance covers. You pay for all of that out of pocket. Car insurance is designed to cover the unexplained, unexpected, catastrophic, costly event. When the truck runs through the stop sign and slams into the side of your van, causing $5,000 worth of damage. That's why you have car insurance. Why is health insurance different? We all know our children need well child checks. We should all be getting our flu vaccine this fall, especially if you work in the area of healthcare. Everybody knows they're going to get a cold or a urinary tract infection, or maybe they might sprain their ankle. We all have things that happen to us, those expected events. Why are those covered by insurance? Insurance doesn't, again, guarantee that care, and it simply can make that care so much more costly. What about the patient with many medical issues? The person with diabetes and hypertension and high cholesterol, and they need to see the doctor on a regular basis. Again, those are expected, and those conditions are going to be better managed when you have a patient, a physician that can take time with you as a patient. One of my new patients this year, he said he'd been diagnosed with high blood pressure years ago. It had never been treated, though, because he couldn't find a doctor that he trusted, that took the time to address his needs. They were more concerned about getting his numbers right. He looked at me, he's like, Dr. Duane, I'm not a number. I'm a patient. I'm a person. And I took the time to listen to him. And yes, his blood pressure was up, and I talked to him about the need to treat that. But we talked about working on his weight issues, his sleep issues, the stress that he was experiencing in his life. How am I able to do that? Well, I didn't have 10 minutes with him. I could take an hour and a half with him. That's the beauty of direct primary care, is it restores that doctor-patient relationship. It's about the relationship. How do we solidify, support, grow that relationship? Well, first of all, as doctors, we need to stop working for insurance companies. I'll tell you, it's taken me some time this year to stop checking off all the check boxes in my EHR, because I'm like, this doesn't make a difference to this patient. If I had to bill the insurance company, I would need to check off these boxes. But it doesn't matter for the care of my patient. Right now, doctors work for insurance companies, and so they're doing the things that the insurance companies want them to do so they can get paid. They're not doing necessarily the things that the patients need them to do to help them to be healthy. I want to comment briefly on the HHS mandate because I actually had the opportunity to testify against it long before it was a mandate. And I testified against that mandate, and I'll never forget, this was 2008, so 8 years ago. I'd only been in the district a few years. I was still a relative unknown. Nobody knew who I was. And I got up there in front of this committee, who all were very respectable and listening, and I described my credentials: an associate professor at Georgetown, author of a chapter on preventive health services, expert in women's health and fertility. And you could see they were sitting on the edge of their chair. The committee was so excited, they were waiting for me to come out and say, this is why we need birth control. And what I said was, let me share something with you. A woman's fertility, a woman's reproductive health is not a disease. Pregnancy is not a disease that needs to be prevented. It's a part of a woman's life. Birth control, the birth control pill is the first drug and the most widely prescribed drug given to a healthy individual to create a diseased state, to create a state of infertility. Why is it that we spend billions of dollars doing this? Well, in large part, it's because of my colleagues and me who are ignorant about fertility awareness-based methods or natural methods of family planning. Although I was raised Catholic, I had never heard the term natural family planning until I was a first-year resident. And thankfully, one of my senior residents told me about these methods, taught me how charting a woman's cycle, a woman and a couple together, can truly make informed choices when it comes to family planning. They can plan to engage in sexual relations or not, depending if their goal was to avoid or to achieve a pregnancy. Physicians do not know about this, and for this reason, I started the FACTS organization to educate my healthcare colleagues. Not about the church's teachings, because it's not about what the church teaches. It's about the science. Our goal is to simply share the science of fertility awareness-based methods, and we use that term because it emphasizes it's so much more than just about family planning. It's about helping women be aware of their fertility, help them to monitor their reproductive health in a way that will improve their health. Again, the bottom line is how can we help our patients be healthier? Empower them with knowledge about how their body works. Empower them to make informed choices. I am excited that although the DPC movement is very small, it is growing. And fortunately, it was around a decade ago, almost, when the Affordable Care Act was started. And it is written into the legislation that if an individual has a direct primary care plan in conjunction with a catastrophic insurance plan, to cover that time when you fall off the ladder while you're painting and you break your leg, because that's not expected, or to cover that cancer diagnosis, which may not be expected. If you have a direct primary care plan in conjunction with a catastrophic insurance plan or a health sharing ministry, it actually meets the Affordable Care Act mandate. Many people may not realize that, but it's out there. We need to grow our network of direct primary care physicians. I will tell you, as doctors, we want to do this because we want to go back to taking care of patients. I want to end by going back to the story of my mom and the day that she gave birth to my youngest sister, because I think it is a wonderful analogy for where we are now. I said, I remember my mom being in so much pain. It was really hard as an 8-year-old little girl to see my mother cry out in pain, to see her suffering. But to watch my baby sister come into this world, to see the pain and the suffering led to the birth of new life. We are going through so much pain and suffering right now in the healthcare industry, in this country, with this upcoming election. This is a painful time, and it's only going to get worse, I think, before it gets better, just like the laboring woman experiences that moment of transition where she thinks, there is no way I'm going to be able to survive this. But it's the strength of the human person. It's the strength of the individual. It's the strength of every single one of us. We must persevere. We must pass through this transition and await that new rebirth of what I envision as a healthcare system that truly seeks to support the doctor-patient relationship and allow us to care for patients. Because within each person is the image of Christ, each one of us a human of the utmost immeasurable worth. And as doctors, we need to be empowered to provide care for every single individual. Thank you.
Thank you so much for your testimony. This is our credibility when Catholics weigh in on healthcare issues, knowing that Dr. Duane is out there and only wants to care for patients. That's something that we definitely need to make possible. When Pope Francis came here to the United States, he visited unexpectedly the Little Sisters of the Poor, who are also our credibility. You mentioned the assisted suicide law, and the only reason this keeps gaining traction is because words like mercy are manipulated for ideological purposes, and nobody wants to say you have to suffer, right? But there's an alternative. And when you look at the Little Sisters of the Poor who care for the elderly poor, they'll give testimony to you that patients, when they feel loved, which they are by the Little Sisters of the Poor, are not begging for death. They're living life to the fullest, and And that, of course, is an issue that has been wrapped up in religious freedom challenges. And Matt Bowman's going to talk a little bit about some of those challenges and what the future looks like. Matt is senior counsel at Alliance Defending Freedom. Thanks, Matt.
In 1992, Nadine Strawson, the president of the ACLU, went to the Senate Judiciary Committee and testified in favor of the Religious Freedom Restoration Act. She said the act would safeguard, quote, such familiar practices as permitting religiously sponsored hospitals to decline to provide abortion or contraception services. A year ago, the ACLU filed a lawsuit in Detroit in federal court to force Trinity Health and its 92 Catholic hospitals to perform abortions. In January of this year, Alliance Defending Freedom, representing the Catholic Medical Association and the Christian Medical and Dental Association and the American Association of Pro-Life OBGYNs, was allowed to intervene in that case to urge that the judge dismiss the case, in part because of RFRA, which the ACLU once said prevents forcing Catholic hospitals to perform abortions. The judge did dismiss the case, but the ACLU has a massive campaign to continue this battle. Just a week ago, they filed another complaint against a Catholic hospital in Illinois, trying to force them to perform sterilizations. Now, the oral argument in the Hobby Lobby case involved a question and answer between Justice Kennedy and the Solicitor General for the Obama administration, Donna Verrilli. And in that discussion, Justice Kennedy said this: under your view of the Obama administration, a profit corporation could be forced in principle to pay for abortions. And the Solicitor General hemmed and hawed and eventually said, you're right, under our theory. Well, not only do we have advocates of the ideology in favor of abortion suing to force Catholic hospitals to perform abortions, and not only do we have the prospect of forcing for-profit corporations and family businesses to pay for abortions, but we have now in California, the state of California, forcing churches themselves to cover elective surgical abortions through all 9 months of pregnancy in their health insurance plan. And Alliance Defending Freedom has filed 2 lawsuits against that mandate, the Skyline Church and the Foothills Church cases. And in June 21st, the Office of Civil Rights at the Health and Human Services Department wrote me a letter after I had submitted a complaint saying we have federal laws banning California from forcing churches to cover abortion in their health plan. The Hyde-Weldon Amendment prohibits this. And the director of the Office of Civil Rights, Jocelyn Samuels, wrote to me and said, we're not going to enforce that law in that way. We don't think that law covers the church that sponsors the health plan, and we think it's probably unconstitutional anyway. Now, if you go to hhs.gov and read the biography of Jocelyn Samuels, who wrote me that letter, you learn that she was the vice president for education and employment at the National Women's Law Center. Well, the National Women's Law Center is a pro-abortion advocacy organization, which earlier this year in 2016 said, we've been hoping that the president would strike the Weldon Amendment abortion restriction and take a strong stand on behalf of women's ability to make her own health decisions. So the head of the office in charge under the Obama administration of enforcing the Weldon Amendment to prevent churches from being forced to cover abortions comes from an organization publicly advocating to eliminate the Weldon Amendment and ignore it because, under their theory, it violates their notion of healthcare decisions. And this notion that we're seeing from the Obama administration and from their allies is one that would deny women and all patients the choice of healthcare that's consistent with their values. And that's ultimately the issue, because we have this new concept of this redefined concept of discrimination. And we're seeing at Alliance Defending Freedom, of course, in many areas relating to the question of marriage being redefined as no longer a man and a woman. But if you go to the ACLU's website on the page declaring that we're going to stamp out discrimination, they say you need to be forced to celebrate gay weddings and you need to be forced to perform abortions. It's all the same thing. That's the position that the Obama administration has now taken under Obamacare in interpreting Section 1557, which says no discrimination on the basis of sex. The Obama administration, not Congress, but the Obama administration has declared that not only forces doctors and health facilities that take Medicaid to not discriminate on the basis of their concept of gender identity, but also on the basis of their concept of termination of pregnancy, which in effect would force, if you're a Medicaid doctor performing a routine dilation and curettage for a woman who had a miscarriage, then it would be discrimination to not also perform a D&C abortion under the Obama administration's own HHS regulations. And that's in a lawsuit right now being handled by the state of Texas and by our friends at the Beckett Fund. They filed their motion, the plaintiffs in that case, to eliminate that agency overreach, filed their motions for judgment a week and a half ago. But yesterday, the court of the Ninth Circuit Federal Court of Appeals filed an order requiring the state of California to respond to a brief that I filed on Friday. Because the issue in that case is that the state of California is forcing pro-life medical clinics to tell women, California will give you a free abortion, call the county to find out how. And the Ninth Circuit Federal Court of Appeals decided 2 weeks ago that doesn't violate the First Amendment at all, forcing pro-life medical clinics to tell women, California will give you a free abortion, call the county to find out how. It doesn't violate the freedom of speech, although just a couple of years earlier, the Ninth Circuit said that if you try to force a doctor not to recommend medical marijuana, that violates the freedom of speech because the doctor-patient relationship is sacrosanct and can involve the highest level of First Amendment protection. But if you force pro-life doctors to tell women, call the county for your free abortion, not a violation of freedom of speech. But that's not just California. I filed a brief in Illinois a week ago, and the court is going to hear our case on December 7th on behalf of a medical doctor, as a member of the Catholic Medical Association, Dr. Anthony Caruso, and pro-life medical facilities and pregnancy centers that where he is a medical director, because Illinois is forcing doctors and health facilities across the state to give women lists of abortionists. If you don't want to perform abortion, you have to give women lists of abortionists. It's a quid pro quo in Illinois. Now, I should probably be carpooling with Dr. Ruppersberger because I'm driving to Philadelphia later this afternoon to argue in front of the Third Circuit tomorrow on behalf of a pro-life organization, Real Alternatives, which the Obama administration contraception mandate is forcing to cover IUDs and the morning after pill, even though Real Alternatives is an organization that has 3 employees on their health plan, and the purpose of the organization is to oppose abortion and to oppose abortifacient contraception. And you can't work there. It's a nonprofit organization. You can't get hired unless you oppose these items and you oppose them being in your health plan. So they're going to force this organization and its employees to have coverage of IUDs in the morning after pill, even though the government admits it won't help anyone to have them have this coverage in their health plan because no one's going to use it. And the government hasn't yet tried to force people to use contraception, at least not in the 21st century in this country. And so it's not going to help anyone. We're going to force them to do it anyway. And I have to argue that in front of the Federal Court of Appeals tomorrow morning in Detroit. Well, meanwhile, my colleague Steve Aden is going to Vermont. And on Election Day, when all kinds of other things are going to happening, he's going to be arguing in the federal court in Vermont because the state of Vermont, which legalized assisted suicide a few years ago, is forcing doctors to tell patients that one of the options that's available for you in your cancer treatment is that we could kill you. And I'm not going to do it, so here's somewhere where you can go to get killed by another doctor. Now, as we just heard, the District of Columbia just voted to legalize assisted suicide. In Vermont, it's not a question of legality, it's a question of forcing it on doctors. And what that does is it means that every patient in the state of Vermont who has a terminal illness or who has a serious illness is being deprived of a doctor who doesn't think killing is a treatment option. So every patient is being forced to go to doctors who consider death and life just kind of options on the cafeteria of things you can get in your healthcare. And that's ultimately the issue that we're facing in the cases that are in front of the Supreme Court that involve our clients at Alliance Defending Freedom, Geneva College and Evangelical College, the Little Sisters of the Poor, the Diocese of Pittsburgh, and Bishop Zubik. And those cases, as we know, the Supreme Court earlier this year issued a somewhat Delphic decision in which they said, well, the government's not allowed to penalize these people, but we're going to send it back to the lower courts to negotiate. What was the government's response to that? Well, there are negotiations that are happening, but what's significant that's happening is that the government started yet another process where, yes, the agency is going to consider new regulations. This is probably the 12th or 13th round of new regulations written by people who have an agenda to force the coverage of these items through Christian nonprofit organizations and somehow to force them to be involved. They're just going to do another round of regulation. And then they're going to go back to the court and say, look, we tweaked it and now we get to start all over and we should win yet again. And so the fundamental issue here, this is a serious issue about whether healthcare professionals, whether healthcare facilities will be able to practice medicine consistent with their beliefs. But it's also an issue, and it's equally an issue about whether their patients will have the freedom to choose them. There are many women who want the freedom to choose a doctor to deliver their baby, and that doctor doesn't also kill babies. But under the ACLU's view and the view apparently of the HHS-OCR, if all women who are pregnant will have to have their babies delivered at abortion clinics because there will only be abortion clinics, because all Catholic hospitals will be abortion clinics. Everyone has to do abortions. And if you consider people like Kermit Gosnell and Brian Finkel and so many abortionists who are now in jail, we don't want our health facilities to be abortion clinics because there are very unpleasant things that happen in abortion facilities. And this point I just want to conclude with was identified years ago by the agnostic anthropologist Margaret Mead. And she studied the Hippocratic Oath and had this to say about it. People consider the Hippocratic Oath as if it's sort of a top-down paternalistic imposition on patients, and that's how the abortion movement views conscientious objections in medical care. But it wasn't that at all. According to Margaret Mead, it was a revolution of patient choice, because before the oath, the doctor and the sorcerer tended to be the same person. He with the power to kill had the power to cure. But with the Greeks, the distinction was made clear. Patients finally had a choice because she said, quote, one profession would be dedicated completely to life under all circumstances, regardless of rank, age, intellect, the life of a slave, the life of the emperor, the life of the foreign man, the life of a defective child. This is a priceless possession, but society is always trying to make the physician into a killer. It's for the sake of giving patients the choice of a physician they can trust that we need to protect the right of conscience of healthcare professionals in our country, and that's what we're trying to do every day at Alliance Defending Freedom.
Matt, going through all of those examples just reminds me to thank the people in the media my colleagues in the media who came today and cover issues like this, because when people start to actually focus on what's going on, it doesn't matter if you're a Democrat or a Republican. These things are bizarre and absurd and distractions to really helping people. So thank you for the work that you do. Louis, do you want to wrap up some loose ends? And
I will.
All right.
I'll be brief. So first, again, really appreciate you all coming. Thank you for this fantastic panel. Just so amazing. Dr. Ruppersberger, Dr. Duane, Matt. Again, my name is Louis Brown with the Christ Medicus Foundation. The mission of the Christ Medicus Foundation, we're a Catholic healthcare nonprofit, but the mission of the Christ Medicus Foundation is simply to bring the love of God, the love of Jesus Christ for each individual, for each person into healthcare, period. And we do that by protecting religious freedom in healthcare, building up primary care clinics, and also through our CURO Catholic Healthcare Ministry. You can find out more information at mycatholichealthcare.com. So briefly, just to try to bring this together, we have an election in a couple of days. And the issues that Dr. Ruppersberger, Dr. Duane, and especially Matt talked about are largely going to be decided in this next congressional session and in this next presidential administration. And these are major issues. People have to realize, Americans of all stripes, regardless of their religious affiliation, is that we are losing our religious freedom, particularly within our culture of healthcare, within the industry of healthcare, at amazing speed, at speed that really would take one's breath away. And it is happening so quickly that I think it is hard for many of us to get our head around it. And the next Congress and the next presidential administration is going to decide a lot of these issues. We're seeing increasingly, with the increased power of the executive, of the White House and regulatory agencies, that a lot of these things can be done or undone without congressional action. And there's a lot of danger there. We're also seeing that most likely, I think, Congress is going to be taking up several of these issues. So I believe that Congress is going to be taking up the issue of the Weldon Amendment that is out there to protect the right of conscience in healthcare and what that means. I think they're going to look at, there's going to be proposals out there to try to address what's happening in California. We're going to see that in the next congressional administration. The Hope of the Christ Medicus Foundation is to see a vote on the Conscience Protection Act, which would codify much of the need to protect religious freedom in healthcare, the right of conscience, and particularly allow medical professionals, healthcare entities to refuse to participate in abortion, in elective abortions, refer, etc. And that's going to happen. We also think that there'll probably be some attempts to write or more clearly clarify the Religious Freedom Restoration Act. That's going to happen. A lot of this will be decided as well by just the fact that so many U.S. Supreme Court justices are potentially going to be appointed over the next 4 years. That's massive. That is extraordinarily massive. The issue of religious freedom is so important because it determines whether someone can be fully who they are as an individual, as a father, as a mother, as a professional, as a person in the community. At our essential point, at the core of who we are, is a spiritual being. However, whatever one's faith belief, people that are of faith, that don't have faith, there's an agreement that at the core of who we are is our spiritual being, who we are, what we believe. And we have to, as this country, as Americans, looking at what our founders put together with the Declaration of Independence, what was enshrined within the Constitution, what's upheld in the Religious Freedom Restoration Act, we have to be who we were made to be, which are a people who are free. That's who we are. We are a people of freedom. We are a people of life. We are a people of true community, true pluralistic notions of living together, truly in community, truly respecting each other's religious beliefs, not just in terms of freedom of worship, but in religious freedom, which carries out all types of expressions, both at home and in the workplace, and as we come together in commerce. And so we believe that's extraordinarily important. And this election is really going to determine a lot of how that all plays out. And we would hope that Americans across the country bring that to bear, not just in the days ahead and on Tuesday, but also as we go forward, recognizing that religious freedom really is the first freedom. So thank you.
And I'd just like to add that, thank you, Louis, that we so often pretend that the most important political thing, that activity that you do, is vote for president every 4 years. That is crucial, obviously, but it's the morning after, all the days after, that are just as important, and people keeping up on these issues and interacting with their elected officials is crucial as well. I want to open up the panel to some questions. News media first, please, because I know you have deadlines we want to respect. Any questions? Or anyone who wants to ask a question is fine. Okay, well then we'll get you out of here so you can get back to work. Thank you very much. Thank you to all the panelists, and thank you. Okay, we do have one. I'm sorry, we do have one question.
Mary, can I?
Let me give you the mic here. Here you go.
Sorry to interrupt. So I came in a little bit late, so this may have already been addressed, but something that Dr. Duane had brought up about the direct primary care model and how she's using it right now, and particularly in the monthly fee of $79 or $200 for a family. I'm wondering, would that be able to at some point, or is this something that people are trying to advocate currently in trying to get that to be covered under like the requirements for healthcare for everyone in terms of like getting taxed during tax season?
Yeah, so I did mention this. There's a lobbyist here in D.C., Jay Keese, who worked with a colleague of mine, Dr. Erica Bliss from Q Lions, back in 2008, and they actually had this written into the Affordable Care Act, so that if you have a direct primary care plan in conjunction with catastrophic insurance, together, that would meet the requirement for the individual mandate. So you would not be penalized by a tax for not having an approved Obamacare plan, because this would meet that requirement. So it is written into the law. I'm sure the way government works, not all laws are executed as the way they are, and I'm sure there are people that probably do have DPC plans with catastrophic insurance that are still getting billed, and they'll probably have to fight that, but it is written into the law such that you would not get taxed if you have the DPC plan in conjunction with either a catastrophic health insurance plan or just health sharing ministry plan alone meets the requirement for the individual mandate. So if you have a plan through CMF CURO, through Samaritan Ministries, it does meet the requirements, so you would not face a penalty tax.
But the other issue is that the tax code needs to be changed, because people that receive their health insurance through an employer get a tax benefit that those who are purchasing their own insurance do not realize. And so we have inequality in taxation because of where people get their health care plans from. So if you work for an employer and you make $100,000 a year and your health insurance costs $25,000 a year because you have a Cadillac plan, then you get an indirect $25,000 benefit that's not taxable. But if you have a job at a local burger place making minimum wage and you have to go out and buy your health insurance and you pay $100 a month or $200 a month, you have to pay that in after-tax dollars, and you do not get a deduction or a benefit from that. So we have an inequality in the tax code that is perpetuating the current system that needs to definitely be changed and move away from employer-based provided insurance plans and let people own their own plans and be able to have them be portable and take them with them if their job changes.